There we go. I'm going to be talking about pneumothorax management today. A little bit on the history of this term. Apparently, it was first coined by a guy named Nick. This physician actually was French. Back in the 1800s, he actually invented the stethoscope as well. That back in the day actually looked more like this. It was pretty much a tube. And what he used to do is actually investigate on the lung and heart sounds, and then he further did some research in autopsies, and then he correlated those things. That's how he found out about pneumothorax, or that's how he coined the term pneumothorax. At that time, apparently, pneumothorax was very, very related to tuberculosis, and which apparently this guy has. But there were other ones that people were having it without any other prior condition, and they at that time were called like simple pneumothorax. Now we have a totally different terminology for it, but I thought that was interesting. Talking a little bit about the incidence of pneumothorax. In England, it was very well studied. This is actually based on research done in between 1991 and 1995. And what they found out is that they had a rate of hospitalization in between 16.7 for men. For women, a little bit lower. Mortality was there, 1.26 per million. And in the US, it was kind of the same. I mean, we have 20,000 patients per year having pneumothorax combined, and we are spending about $130 million. This is all based on data from the guidelines. About the terminology of pneumothorax, we have 4 pneumothoraxes. Speaking of this one, the primary spontaneous pneumothorax is the one for what we don't have an underlying etiology, or it's not that easy to find just at first glance, looking in a CAT scan, looking in an X-ray. That's what we're going to call primary spontaneous pneumothorax. Later on, we're going to talk a little bit about this and to say that there is actually a pathology behind this. For secondary spontaneous pneumothorax, it's much easier actually to recognize this because mostly these patients have problems in CAT scans and everything. They have actually prior history of COPD, they have emphysema, AIDS, stuff like that. Traumatic is related to trauma to the thorax, and iatrogenic are secondary to lung biopsies, central lines, and stuff like that. I'm going to be focused more on the first two, and specifically more on the primary one, where most of the research that has been done on pneumothorax is being focused on primary spontaneous pneumothorax rather than in secondary spontaneous pneumothorax. So this is what I meant by the etiology from primary spontaneous pneumothorax. There are so many theories, concepts about what the reason for these people is for them to have a pneumothorax, even though it's not that clear as in a secondary one. But they are pretty much these 3. I mean, there are many other ones. One better known than the other one, I would say, maybe emphysema-like changes was kind of the very first one that was discovered. Then there was some smoking kind of risk factors that were found out. And then this very last term that I like and I found very interesting, which is the concept of pleural porosity that we're going to talk about later. So emphysema-like changes, this was actually very well described back in 1990s. Taking a look at CAT scans of people with primary spontaneous pneumothorax, and they found out these little changes there, mostly on the upper part of the lungs. And then this is the best study actually done regarding this. Back in 1993, Dr. Benz was the one who selected non-smokers and non-alpha trypsin patients. And she found out that patients with those characteristics with a pneumothorax were having up to 80% of these changes, emphysema-like changes, compared to none on the control ones. So that's why they came with this idea about these emphysema-like changes as a reason for these patients to develop pneumothorax. Smoking, that was very well described back in the 80s. Actually, it's there's a 9-fold risk of pneumothorax, primary spontaneous pneumothorax, on people who smoke. And that's very important because whenever we talk to our patients, sometimes, for example, I had that kind of problem, a patient who had prior recurrent primary spontaneous pneumothorax, who came to the clinic. She wasn't a candidate for surgery. What do I do? She was still a smoker. So that was kind of the things that you can do for prevention, at least, that you can tell to the patient. That's specifically what this study did. This is a study from the Netherlands, and what they did is with psychologists, They gave a call to every single patient who had a primary spontaneous pneumothorax, telling them, hey, if you continue to be smoking, they were smokers, there is a higher rate that you're going to get a second one. Unfortunately, 80% of them continue to smoke. So just to let you know that sometimes these things are very difficult to happen. Not to say that we shouldn't do it. And this is the term that I was telling you about as a third very interesting one for a reason for these patients to develop a pneumothorax, meaning the one so-called pleural porosity. And this came back in 2004 by Dr. Nopin, that we're going to hear a lot about him later on in the lecture, from Belgium. He started this whole thing with a case report. So what he did is that he had a 28-year-old patient who had a spontaneous pneumothorax in the past, who had a recurrent spontaneous pneumothorax in the past, and then he convinced this guy to have a thoracoscopy. But this wasn't like a normal thoracoscopy. This guy, what he did was FEED, which is a fluorescein enhanced autofluorescence thoracoscopy. What it is specifically? So fluorescein is already kind of a contrast that is well used actually for kind of retinal studies. It's pretty much like the contrast for angiographies, let's call it like that. So this, for example, is normal. And I'm not an expert, but this is definitely abnormal. So that's how they use fluorescein, at least the ophthalmologists. In this particular case, this is an IV form of it. And it has been proven to be totally safe. It's completely okay to be given IV. This guy, Dr. Nopin, he used it as a nebulization. So he did that 15 minutes before this guy went into thoracoscopy. And this is a cat, but the concept here is that fluorescein, it's emits a green light by the time you put some blue light on. Kind of like that. I don't know if this cat had fluorescein, to be sincere, but I think it's a nice example. So that's what it is. That's what it is, this thoracoscopy. He's going to put a blue light on a patient who already had fluorescein. And we're supposed to see something green as something positive. And this is a thoracoscopy. I'm sorry for the picture, but that's the best one I got. And as you can see, the abnormality is 2 × 3 centimeters. This is at white light. So this is what he saw. And then he put the blue light, and he found out that the problem was even larger. It's 5 × 7 centimeters. And he was emitting a green light. So that's his case report. Then later on, he said, that was in 2002. Back in 2006, he came with another idea. This time, actually doing the same kind of procedure, meaning FEED, the fluorescein thoracoscopy, on patients with primary spontaneous pneumothorax, but this time he compared with normal subjects. That's actually a good idea, pretty much based that nothing happened to this guy on the case report. This was done 4 years later. The control ones were patients who were supposed to have a regular thoracoscopy by, it was just a sympathetic cholesis, that's it. So they were supposed to be normal guys just going for thoracoscopy without any other prior lung disease or lung problems. So there were 12 patients having prior history, primary spontaneous pneumothorax, and he had 33 controls, these patients that went for thoracoscopy just for sympathetic cholesis. And then he checked on these things, these changes by thoracoscopy only, himself, 100% normal lungs, low atronchotic changes, high antrochotic changes, blebs and bullets. So he found out that obviously the controls were having normal lungs. Low antrochotic changes, they were even in the control ones. The red one means that there is no significance. So overall, he found out that there were more changes on people with primary spontaneous pneumothorax than in the control ones, which makes sense. And then he puts the blue light. These people receive fluorescein on the primary spontaneous pneumothorax. And he comes from 1+ to 3+, meaning how much green light is he seeing by the fluorescein. And I'm just presenting the 3+ because there wasn't any significance with the 1+ or the 2+. This is according to him, what he saw. So on 3+, he found out that people with primary spontaneous pneumothorax were having more green light emitting. Now, the next question is, does that correlate with patients having bleps or bullets? Like these same patients, this same primary spontaneous pneumothorax, and there wasn't any correlation. So here's the theory, and this is just a theory, and this is just a study. It's very interesting, but I think it's good for us to know anyway. And what he based, his conclusions were that maybe that's another reason why these people develop primary spontaneous pneumothorax, is that they have some sort of inflamed cells covering the visceral pleura that at some point produce some air leak. And then he had the question, why then just resecting bullets, we have a recurrence rate of 5 to 10%, and why we do a pleurodesis, meaning a more diffuse kind of management, the recurrence goes lower? That's what he's basing his whole idea, meaning that there is something else besides the blebs and bullets, and that's why we should pay attention to them. Just preliminary data. Dr. Light, go ahead.
Why does the fluorescence go to the inflammatory cells? Why is it gathering in that area rather
than somewhere else?
Yeah, or even, why is it even gathering?
So he found out this on the very first case report, that there were more stuff, more cells there on the visceral pleura supposed to be that were catching this kind of contrast, to say the least.
Like when they do it in the eye, it's diffused.
When they do it in the eyes, it's an IV form, and they do it as a contrast. When they do it in the lungs, it's just a net form. This is just theories. So he mentions that maybe that's the reason why these people may ended up having pneumothorax. What it is exactly, nobody knows, and it's not proven, obviously. The other theory that I didn't mention earlier is the morphometric kind of theory that everybody knows about. The taller people tend to get more pneumothoraxes than smaller people, and this is all based on the idea from Dr. Light on this book about the gradient on pleural pressure. And this is based by the fact that the gradient on pressures of air is very different from the base to the apex. So if you're taller, you're supposed to have more pressure, more gradient, that is pretty much based on the apeces, where you ended up having pneumothorax. Talking about secondary spontaneous pneumothorax, Dr. Sun already described pretty well in this review from the New England about the causes of it, and we already know about them. I'm going to go from the most common to the least common one. Most commonly one seen COPD, cystic fibrosis, asthmatic patients, people with infectious diseases, PCP, connective tissue diseases as well are present, and ILDs, sarcoidosis included, and cancer as the least common ones for them to have secondary pneumothorax. Now, I'm going to get into the management of a pneumothorax. Once you have a pneumothorax, what you do. And we have two main guidelines. Number one is the one from Britain, the British Thoracic Society. These guidelines are from 2010, and then we have the American ones, which are from 2001. Now, pay special attention here. These are not guidelines, because if you go to ACCP, you're not going to find it on the section of guidelines. You're going to find it in the section of consensus, and that's what it is. It's a consensus, and they use this term called Delphi consensus. And again, it's from 2001. It's not in comparison to the one from England or Britain that is from 2010. So this is what you find on the consensus. Unfortunately, by 2001, the committee, they gathered and they found out that there were not enough evidence, unfortunately, at that time. And they came out with the idea that we're just going to need to do it by expert opinion, unfortunately, because there's not that many randomized controlled trials. So this is all based on the assumption that individual kind of judgments are not as good as a group judgment. And that's why he came out with the idea about a Delphi method. So Delphi is actually this place. This is Greece. It's the Apollo temple, something like that. And apparently, at that place, there was an oracle. So initially, the method was called the Oracle of Delphi. But then the group who actually invented that in 1940s, they decided just to keep it as Delphi. So that's why the name. What it is specifically, so the Delphi process is pretty much, they put an expert panel, a lot of people who are supposed to know about the topic. They make questionnaires, they make questions, they send it to another experts, they receive the feedback, the answers, and then they make new questions. What's new about this kind of method is that because they are not in a room, there's no face-to-face interaction. So whatever opinion I have, it's gonna be a free opinion without nobody watching me or saying what I'm doing. And this is pretty much because there was lack of evidence. So that's what they decided to do. And this was kind of the questionnaire. They put a case, they were sending the cases, and then the physicians, the experts, were responding depending of from 0 to 1 or 0 to 9, depending what the management would be that they are comfortable doing. However, it's not just that. They found that there were some trials, unfortunately just 8 at that time. And as you can see, they didn't include that many patients. We're talking about 11 to 30, maybe 100 patients. That's what it was in 2001 by the time these people gathered. Compare going to the British ones, these ones are from 2010, and there were more evidence actually at that time. And we're talking about 9 years later. So the first questions by the time we have a pneumothorax is what the size is. I think that's the very first thing that we ask ourselves to try to consider what the management would be at the end. So let's go back to the guidelines. This is a very interesting study because what they did was, okay, if everybody's agreed that the size is very important to start management on pneumothorax, then why, whenever we read the guidelines, we get two different senses? And here's the problem, that we don't have a specific consideration for what is large and what's small worldwide. It differs if you check on the guidelines from ACCP, the American ones, or if you check the ones from Europe. So these are the three main guidelines that at that time this doctor checked: the British one, the American ones, and the one from Belgium. And she found out that there were three different kind of concepts for calling a pneumothorax large. It was more than 2 centimeters for the British guidelines, more than 3 centimeters in the American guidelines, and actually the people from Belgium, they take it even further away. They want actually the entire length, they want a pleural gap in between the entire length of the wall and the lung. That's for them large. So she tried to gather 49 cases of patients, and she tried to categorize these ones in between small or large. And unfortunately, there is not a good consensus, as you can see. So the British, they call 10% of them large. The Americans, they call 49% of them large. And maybe with the one with Belgium, there is more of a consensus. As you can see, it's 47. So what does this mean? Is that there is a problem because you don't know which guideline to follow because it differs for how they call it large or not. And unfortunately, this is the primary question that you have by the time you have a pneumothorax, if it's large or small. And that's a problem for research as well because you cannot make like a meta-analysis because then you're going to have two different considerations for what is large or what's small if you compare American studies or European studies. What I'm going to present right now is actually a very nice algorithm that the British guidelines has. So let's say you have a spontaneous pneumothorax. Let's say that the patient is stable, and let's say it's not bilateral. You find out that the pneumothorax is a primary pneumothorax, so there is no an easy underlying kind of pathology seen on the CAT scan, or the patient doesn't have any prior lung diseases. And let's say that the pneumothorax is small, is lower than 2 centimeters. Let's say we're going to follow the British guidelines. So what they mention is that you should consider discharging the patient and just follow an asylum patient. The American guidelines, they're kind of okay with that as well. It differs a little bit because they want some sort of observation, and then 3 to 6 hours later you can discharge a patient. It's a follow-up X-ray. It's okay. Kind of the same concept anyway, to try to manage these patients as an outpatient pretty much.
Eric, sorry, maybe you did it and I just missed it. Could you define what you mean by 2 centimeters? Where are we measuring from? Is it lateral?
That's a good question, and that differs as well. Here's the problem. The American guidelines, they want 2 centimeters to be large in between a pleural gap in between the cupula and the apex. That's 2 centimeters for them. More than 2 centimeters, that's large. The British guidelines, they don't do it there. They do it at the level of the hilum. So the pleural gap is supposed to be more than 2 centimeters there in between the chest wall and the lung.
That's lateral.
That's laterally. So that makes it even more confusing. It's not just the numbers, it's where are you going to check for it.
There was a third way, if my memory serves, that you can volumetrically figure out what percent.
There are many formulas. It's not just one. I found out like at least 3 of them. The Kirchner, the Collins, the Light formulas, all of them very controversial actually, if they correlate with CAT scan or if they correlate with some sort of volumetric studies. They approximate, but still you're not going to find a good consensus about them or a specific one saying this is the one. Unfortunately, there is no consensus. So we were here. We were talking that maybe in considering this kind of very mild pneumothorax, it's pretty much the same management, outpatient, X-ray, fine, nothing's going to happen. But here's the first problem. Let's say you have a bigger pneumothorax. Let's say your pneumothorax is more than 2 centimeters. What the guidelines from Britain they suggest is aspiration. And I'm going to tell you what that is later on. But the American ones, they are very clear about chest tube only. That's it. So I'm not going to go over how to do an aspiration. If you want to double check, if you're interested, actually you can find it in the New England. What it is pretty much second intercostal space, mid-clavicular line, 16 gauge needle, go all the way with a 15 ml syringe, and you just suction. That's what it is, aspiration. I'm going to tell you later why this doesn't look to be the best idea ever. And here's the thing. You go into Cochrane, there is a very nice review about simple aspiration versus intercostal chest tube, versus chest tube. Because what we want to know right now is which guideline to follow, either a chest tube or either aspiration on those kind of patients who are, again, stable patients and or minimally having symptoms and having a pneumothorax, let's call it 3 centimeters to make it even for them. Here's the problem. There wasn't enough evidence. It was just, they review a lot of the studies, but the only legible one was from this guy, Nopen, in 2002. The same guy about the fluorescence stuff. And this is a study. It was done in 2002. What he did, and it was very interesting, this is a multi-center to begin with, prospective and randomized trial. Everything is good, but it's a pilot study. And I'm going to tell you what that means later on. So, and he compared aspirations and chest tube. So he had 60 patients. I'm talking about just primary spontaneous pneumothorax, this case only. 27 went for manual aspiration and 33 went for chest tube. He had 16 successes on the manual aspiration. He had 21 in the other side. And there is no difference. So that's okay. Apparently manual aspiration was, immediate success was the primary goal. There is no difference. Then he take a look in other variables, and apparently the only significant one, meaning that the only difference is hospitalization, which makes sense because you're going to put a chest tube, patient's going to end up hospitalized. If you do aspiration, patient's going to go home. But other than that, there was no major difference. If you keep reading, here's what it appears. The power analysis for this study is very, very low. And all endpoints equalities shouldn't be considered as formally statistical proven. So it's okay to have these numbers. He found out interesting results. Unfortunately, the evidence is not that good yet because of the number pretty much. And they put it very clear there on the paper. Now, once you take a look at this kind of articles, you need to make sure that both groups are equal. So as you can see, they make sense: gender, age, BMI, light index, which is the same kind of formula, smoking status. Everything makes sense. Seems like the two arms are equal. But if you take a special attention in the smoking status, Doesn't look like that, because what they did is they make that the current ones and the former ones one number, and that's how they call smoking status. But if you take a look on the current ones, we're talking about 10 versus 25, and that looks different. And if you just base your smoking status on that the patients were currently smoking, you have different numbers. You have 37% versus 75%. And unfortunately, that's significant. So to begin with, on this study, if you pay special attention, the groups were not equal. So let's go back to what Cochrane mentioned. The implications for practice is that even though, well, unfortunately, it was the only study available that they checked, there is not that many implications for practice. The evidence is not good enough yet. The only thing is that patients are not going to be hospitalized, which makes sense. But other than that, you cannot came out with any other ideas from this study. And unfortunately, checking into the guidelines, the British guidelines, they base this whole decision on that, plus expert opinion.
Eric, well, if you can go back to the previous slide. So this was a randomized
Exactly.
trial?
It was a randomized.
How did they do the randomization?
So apparently they have a patient, and then I don't know, it's not that very clear, but it was interesting as well. I mean, how did they do the randomization? But what they mentioned is like they had a patient with pneumothorax. They did some sort of randomization. They came out with a letter, and then they said, okay, you're gonna go for the aspiration. Okay, you're gonna go for the chest tube. You agree? Yes. Okay. Done. Yeah, it's interesting how did they do it, because even though it's a well done study, I'm not saying it is not, because it's randomized. It's supposed to be blind, and it's prospective. Unfortunately, it's a pilot study. We don't have that many people enrolled, and there is some problems with the groups.
Yeah, the big difference in the smoking status suggests that there's some other factor that wasn't actually randomized.
Yeah.
Because that's pretty striking to see the difference between the two.
And that's pretty much what Cochrane mentioned. I mean, even though this is the only study, unfortunately, we cannot make any decisions based on this study. So going back to the algorithm, we're talking about spontaneous pneumothorax. Again, people maybe with more than 2 centimeters pneumothorax. Aspiration, that's what people in Europe do. But then the ACCP recommends a chest tube. Now, here's not that clear, because you have two options. Either you go by a large chest tube, or you go by a small chest tube. So this is a very nice review published in Clinics. They go over these kind of problems: what size, what type of chest tube you use for specific problems, including pneumothorax and pleural effusions. So what to choose? Then you have a 36 French chest tube that is ubiquitous in the hospital, or you have a Wayne catheter that we have it in the Bronx suite available, and we're supposed to have it pretty soon in the ICUs as well. This is 14 French. So the idea about maybe using a small bore chest tube compared to a large chest tube, it's based on this study. Now, this study is from 2003. They compare two kinds of chest tube. They compare a 9 French chest tube, this black one, and a 20 French chest tube. Now, I'm going to tell you later about this 9 French chest tube. This was done in Australia. So this is a retrospective analysis. ICC means intercostal, means chest tube, and PC means pleural catheter, pretty much a small bore catheter. So they found 67 patients, 31 in one arm, 36 in the other one. Patient characteristics based on age or prior history, no difference, that's okay. Then you take a look into the results, and apparently there wasn't any difference either. That's good. I mean, success rate was the same, left on stay was the same, complication was the same. But if you really want to be mean, take a look in the complication and recurrence rate. You see that even though it's not significant, the numbers, they are different. You have 9 in one arm, you have 3 in the other one, you have 6 in one, you have 2 in the other one. It's not significant, yes, but still it looks different. So now you take a look in the complications, and most of them happen on the pleural catheter. I'm talking about the small bore catheter. And if you make them both together, then it is significant. This is just an observation about this study, meaning that apparently there is a trend for a small bore chest tube to have a little bit more of a complication of recurrence rate of the pneumothorax, because that's what you don't want once you pull the chest tube, that the pneumothorax would recur. So here's the problem. This study is the very first study checking on efficacy of small bore chest tubes. Unfortunately, we're having small numbers, so the power, and they mentioned this is taken from the article, the power is not the best. So this is inadequate power, and maybe what we are looking at is a type 2 error. Why then small bore chest tubes may have more recurrent rate? Very minimal, still with a lot of problems going on. And they mentioned something interesting, which is that maybe what's happening is, like, by the time you put a very small bore chest tube, there is no enough irritation of the pleura, so both pleura can stick together. And that's why maybe large bore chest tubes are better. That's their theory, that's their idea. This is a retrospective study again. There is no randomization here, so it was a doctor's choice to go either for one or the other. We don't know why or how. They checked for other variables, and apparently they were okay, but we don't know what's behind. And here's the thing that I was going to tell you at the beginning, is that this 9 French chest tube that they use, the small bore chest tube, it's not the same as the one that we have. The one that we have is a Wayne catheter, which is a little bit more flexible. Better, supposed to be. There is no studies based on this. So just to talk a little bit about small and large bore chest tubes. So this is the nice algorithm from the British guidelines. As you can see, it's pretty much aspiration and discharge, and at the end, a chest drain, that's fine, but still, they always will recommend an 8 to 14 French chest tube, meaning a small bore chest tube. If you take a look into the ACCP guidelines, for stable and unstable patients, large pneumothorax, meaning more than 2 centimeters, they still recommend small bore chest tubes, even though you can see that maybe a chest tube is not that bad to do. But here's the caveat. You can do a small bore chest tube, that's fine, but there is this is based on expert opinions, this is based on small retrospective studies, this is based on just really small data, that if you don't put a large chest tubes, it's not okay, because there is risk that these patients may end up intubated or under mechanical ventilation, and the probability for this to recur is larger. So that's why if you think to put a small bore chest tube, that's fine, but just watch out for people who you think that may have a large bronchopleural fistula, or they're going to end up intubated under mechanical ventilation. That's based on the guidelines, that's what they mention. Again, this is all theories, and this is all based on really not that good of a data. Now, I review this, and apparently, yeah, there is no enough data about this. This is the only study done with pigtails catheter, a small bore chest tube, on people who are mechanically ventilated, and let's see what happens with them. This is done in China. So this is a retrospective study again. They found now 70 patients with a pigtail ended up intubated under mechanical ventilation. They were 48 that succeeded, 22 failed, and they ended up like a good number on a large bore chest tube because they had initially a pigtail, and they were failures still. What they wanted to know is that what happened for these patients with a pigtail under mechanical ventilations for them to fail. So let's check retrospectively, and let's see if we find any variables.
Eric, what did they identify as failure? What did they constitute failure for chest tube?
Ending up on a large bore chest tube, surgery, or they expire. Okay. That's not successful. So these are the variables. Significant one is FiO2 60%, meaning that people who were having an FiO2 of more than 60% were supposed to fail more. The PEEP, there is a difference, meaning people with more PEEP supposed to fail more than people who were not. We're not talking about really big difference. We're talking about 8.7 versus 6.3. and sets apparently was a difference. So here's the problem with this study. I mean, this was the first study on reporting efficacy and safety of small bore chest tubes in mechanical ventilated patients. This is done in China. This is common practice there. They found out 68.6% success rate. That's okay, but this is a retrospective study still. The number of patients we're talking about are very, very small. I think it's up to 70 patients only. And there is no comparative results to large bore chest tubes. We're just talking about people with small chest tubes and what happened to them. That's it. This is not a comparative study. And then what about you put, let's say you have a patient who is mechanically ventilated, you put a small bore chest tube based on this study. Let's say that we do what this study tells us to do. We know, and this study let us know, that the people who ended up on more FiO2 or more PEEP, they have a chance for this not to work. Now, how can you tell? You can tell, but you're not 100% sure how much your patient is going to need FiO2 and how much PEEP your patient is going to need. And we're not seeing like crazy numbers. We're seeing 60% FiO2, PEEP of 8. That's not that bad. You can tell by this study that they're going to fail. So I wouldn't advise that as a common practice, mechanically ventilated patients, again, only. Now, what happened with the iatrogenic ones? Central lines, TBBS, stuff like that. What happened if you put a pigtail? So this study was done in France. For them, it's common practice there in France to do a small bore chest tube on everyone, in the units, in the ER, no matter what. So let's say what they have to say. Apparently, they had, this is a retrospective study again, so they checked 400 plus spontaneous pneumothorax and iatrogenic ones, and they wanted to see if there is any difference in between same management and what happened to them comparing iatrogenic and spontaneous one. They have good numbers there, and as you can see, they divided the iatrogenic one in between central lines, thoracentesis, and others means biopsies. These are the numbers. And the main thing here is that apparently, even though these are iatrogenic pneumothoraxes, we're not talking about primary, secondary pneumothoraxes. We're just talking about regular people when they're having a pneumothorax. Having them a really small bore chest tube is not that much of a problem because the number is just 2.3% of them ending up on VATS. This is just what they found out retrospectively. So this doesn't clarify everything about what to use, but definitely I would say that a small bore chest tube is still a good idea based on not that well done studies, based on expert opinion, if your patient is not going to end up on mechanical ventilation or you think that the patient is going to have a big bronchopleural fistula. Is that a good idea? Yes. Is that checked by the guidelines? Yes, at least the American ones. And the British one as well.
I have a question.
Mm-hmm.
Going back to that study,
Mm-hmm.
did they comment on the etiology behind the secondary?
No, they didn't.
And the reason I beg the question is because, again, I think there's a possibility that you could have another type 2 error here. So everybody knows what a type 2 error is. So you basically say that there's no difference, you're accepting the null hypothesis, there's no difference between the two groups, even though the reason may be false. And so you wonder if your secondary pneumothorax people have a different underlying etiology, obviously, than the primary, and so whether or not that would have been indicated for that group irrespective. That's one of the questions. That's why I asked what the reason was. So. No,
they didn't mention it.
Okay.
So let's say you choose to do a chest tube. Let's say you choose to do a small bore chest tube. And the next question is, you do suction or not? And Bangman, who is the ACCP president nowadays, he may be the expert here on pneumothorax. He mentioned this on a review article that he did in 2006, that apparently the variability in suction recommendation is pretty much derives from limited evidence. There is lack of evidence here too, unfortunately, on the suction role. So let's take a look what the guideline says. So the British guidelines, they mentioned that suction shouldn't be routinely employed, and there is supposed to be a special attention on possible re-expansion pulmonary edema that I'm going to talk later on. That does happen. And the American guidelines, they mentioned that suction should be applied if the lung failed to respond. Kind of a diffuse concept. And this whole thing is because in theory and by expert opinions and by anecdotal kind of cases, there is still the concern that if you put a patient on suction right away once you have a chest tube, there could be a persistent air leak. Number two, re-expansion pulmonary edema. So re-expansion pulmonary edema is a real thing. It happens in between 0.9 to 29% of the time. It's the mortality is very high. We're talking about 20%. And what the management is for this entity is very variable. I've seen different cases and they don't correlate with each other. The only correlation I found is supportive therapy, put the patient on the vent, that's it. You're going to find diuretics on one side, you're going to find fluids in the other, you're going to find steroids, but pretty much it's supportive management, and that does happen, and the mortality seems to be very high. This most likely and in theory to happen on patients who has a chest tube and they are put right away under suction. So looking into the evidence for this, because this is just based on assumptions, this study is from Japan in 2013, very recent. So they went and take a look on all prior pneumothoraxes that they had. And they take a look at what kind of variables those patients that ended up having a re-expansion pulmonary edema, what do they have? What makes them different to have this problem? It's a nice study. And these are kind of the methodology that they found to check for this variable, how big a pneumothorax was or how small the pneumothorax was. Because obviously we do know that there is a big difference if you follow the guidelines. So they use this equation. And they have 173 episodes of pneumothorax. And the incidence here for re-expansion pulmonary edema, they had 27 patients, meaning 15%, which is about the incidence that has been described between 0.6 to 29.6. And these are all the variables. The significant ones are these two, symptoms duration and pneumothorax size. But what about aspiration? What about the suction? It's not significant here in this study. So again, there is a lot of assumptions, there is a lot of theories behind this. This is the only evidence, unfortunately, about the role of suction for this patient to end up having this expansion pulmonary edema. And this is not the best study, yes, because this is a retrospective study, again. But at least we can tell, and we can get from this study, that if your patient has more symptoms for quite a while, there are higher risks to develop expansion pulmonary edema, as well as if the pneumothorax size is bigger. If you have a bigger pneumothorax, which makes sense, right? Because you're going to start sucking air out, and it's supposed to be bigger forces, and that's how you ended up on pulmonary edema. So that's the significant part of this study. Taking a look into recurrence prevention. Mm-hmm.
What did the people die from?
Here?
Was it just hypoxia or something, or was it? What
They didn't describe it. No, they didn't describe it. No.
It's a high mortality.
Yeah.
Even though that's statistically significant, the odds ratio of 1.05 is very small. That
Where?
odds ratio
Under your
Yeah.
multivariate analysis.
Yeah.
odds ratio of 2 would be like a two-fold increase. Right? Odds ratio of 1 would be no increase.
Hmm.
It's 1.05. No, statistically significant.
So talking about recurrence prevention, let's say again, you have a chest tube in, you have a small bore chest tube in, let's say you choose not to do suction, your patient's doing well. The next question you have to ask yourself is, what about recurrence prevention? For primary spontaneous pneumothorax, it has been well described that after the first event, you have a risk of 30% to have a recurrent pneumothorax. After a second one, 62%. After a third one, 83%. Now, what do you do after you have a patient with a primary spontaneous pneumothorax having an event? What do you do to prevent this to happen again? Now, you're going to find that in the guidelines, they don't mention do something right away just for the first episode. And this is why, even though the number looks scary, right, because 30% are going to end up having a pneumothorax again, it's mainly because you have to think about the other factors, meaning the risk for the surgical intervention, meaning patients who are going to end up having chronic pain, paresthesias, meaning morbidity and mortality for this event, plus the fact that a primary spontaneous pneumothorax that recurs is not the same as a secondary that recurs. It's more life-threatening, the secondary ones. The primary ones, they may have some symptoms, they may end up in a chest tube, but there is lower mortalities compared to the other ones. And that's what the British guidelines mention. They have these specific ones that they are supposed to go into recurrence prevention, meaning a second one, meaning bilateral ones, meaning persistent air leaks, or specific people who are pilots or divers. Then you think about maybe doing something, because then you have another factors in place here. And now you can say, okay, maybe the risk for surgical intervention is not that bad. Chronic pain doesn't matter. For secondary spontaneous pneumothorax, it's very clear that there is 50% chance that this may recur over 3 years. And the ACCP, they do recommend that something has to be done, because it's lethal if this recurs, and for sure it's going to recur. We're talking about bigger numbers here. So let's take a look what the strategies are, because recurrence prevention is pretty much surgery. So it's pretty much cut and paste. So what you do is you have to resect bullous and ablebs, and you obliterate these kind of emphysema-like changes that we already described. So that's cut. And then you paste the pleura. That's pretty much the two objectives of a surgical approach of recurrence prevention at the end. Now you have two possibilities. You either do VATS or you either do open surgery. So what's the evidence behind this? This is a nice meta-analysis from 2007. So what they did is they just focused on recurrence, because that's your main objective. Recurrence prevention, this not to happen ever again. They found out that there were many non-randomized trials. We're talking about 16 non-randomized ones and 3 randomized ones. And then they checked for the relative risk for these patients to end up having another pneumothorax. Just at first glance, you can see that mostly all of them favors open surgery. And you take a look at the relative risk of the non-randomized one, it's 4.9. For the randomized one are 4. And overall, if you combine them all, it's still quite significant. It's 4.7. That's okay. We all agree that maybe there's lower recurrence rate on people who have an open surgery compared to VATS. But that's not the only factor as well. Going back, it has been already well established that even though there is a lower recurrence rate, you have more blood loss, you have more pain, you stay in the hospital more. If you go by the economics factor, there is more economic loss if you do an open surgery, and there is obviously better pulmonary gas exchange if you do VATS. That's more of a surgical kind of matter that they're still discussing, and it's very controversial. And there is a study actually that they did in England, and they found out that, how many people, what the surgeons are doing for recurrence prevention on pneumothorax. And they did it over some years, and at least they did 3,000 VATS compared to just 1,000 open surgeries. So it's not just the evidence, it's what the surgeons decide to do, which means that they prefer still to do VATS. They know that there is maybe a bigger recurrence rate, but still there are other factors playing here. So this is kind of a summary for what we discussed, that primary spontaneous pneumothorax, it does have an underlying pathology. It's not just clear lungs. There are many reasons. Smoking cessation is very important. There are many guidelines differences. If you go by the British one, if you go by the American ones, you're going to find a lot of differences. And this is mainly because there is lack of evidence on this specific topic, pneumothoraxes. Aspiration, I wouldn't advise it based on this only evidence that we already discussed. And small bore chest tubes, I think is something to really highly consider unless your patient is ending up on mechanical ventilation, meaning positive pressure. Suction, as well, it's not highly advised because of these factors that even though there is no big evidence about it, can happen, and they are very bad, meaning pulmonary edema, meaning persistent air leak. A second, primary spontaneous pneumothorax, they need recurrence prevention. We need to have the surgeons on board. And for a secondary spontaneous pneumothorax, for sure, this needs to happen. And then we get into the discussions about doing VATS or open surgery, but this is more like a surgical matter.